My name's Azim. I'm a recent surgical academic foundation training AFP, surgical AFP in London at Guy's and St. Thomas's Hospital. Biomedicine is a company that I co-founded with a bunch of my friends about a year ago. And we've been running this webinar series, or a couple of series now, for about a month during isolation. And thank you for everyone's kind words and all the amazing feedback that we received for the last 6 lectures. So it's been really, really positive. We obviously advise you guys, if you haven't already, to please join us on Biomedicine for Students on Facebook. That's where all of our initial and kind of all our most recent updates are going to be, as well as on Instagram as well. And anyone who's joined up via email will continue getting links and invites as well. So this crash course, kind of respiratory crash course on 2 different topics, it's going to last just over an hour, we reckon. We have a bunch of doctors in the chat as well, who are admins, and we'll try and reply to your questions as we go along as well. And if you haven't been here before, these are super interactive, probably not like a webinar that you've had before. So we would advise to please have your mobile phone to hand. We're going to do some interactive questions as well. And all we really ask from you guys is to please just leave us feedback at the end of this. We also have a super amazing platform coming out in the next few days, so keep your eye out for that, and we'll send you more information. So let's dive right in. So we are finishing off our respiratory series from last time with 2 super common conditions that you guys need to know about, particularly as you transition out of medical school. So pneumothorax and pulmonary embolism. So we use a case-based approach to help you identify your top differentials, why these are, and covering really everything about these topics that you really need to know through your foundation years anyway. The pathophysiology, diagnosis, investigations, etc. And like I said, we use a really interactive approach. So we use something called Mentimeter. So like I said, you have your phone to hand if that's all right. And we can do all of our interactive kind of questions together. And finally, for those who haven't been to a biomedicine webinar before, we use a multi-step SBA approach rather than a single best answer approach, if that makes sense. So we cover the journey of the entire patient from their presentation all the way to their management and discharge. So our platform, which comes out in a few days' time, has hundreds and hundreds of these questions as well. So yeah, great. Let's dive right in. So case number 1, we have a 23-year-old male who has presented with sudden onset left-sided chest pain and shortness of breath after he met up with his friends, which he shouldn't be doing unless he's 2 meters away from them. He is usually fit and well. And on examination, there is left-sided hyperresonance on percussion and diminished breath sounds. Interesting. As you can see, there he is with his pain on the left side of his chest. Observations, those were his observations. So we already kind of know what's going on. We think this is a pneumothorax, but have kind of some other differentials in your head, and we're going to run through a bunch of questions, and we'll talk through pneumothorax as well. So having a look at his observations, anything that strikes you on those, anything you're worried about at all? Exactly. So he's tachycardic, he's tachypnic, and his SATs are low. Precisely, brilliant. So we're a little bit worried about this guy. We think it's a pneumothorax. His obs are kind of in keeping with that a little bit. So let's dive into the first question. So if you guys could please go to www.menti.com and use the code 690679. And this will be our first question. So which of the following is a risk factor for this type of pneumothorax? So read the question carefully and have a think. Which of the following is a risk factor for this type of pneumothorax? The question is just at the top of the screen there. So I'll give you guys a few moments to have a think about that. Which of the following is a risk factor? So let's have a look at what you guys think. Interesting. Okay, so we've got a mixture. Main split here is between trauma and smoking? Let's have a look at the correct answer. So yes, the majority, well, just about the majority of you guys think it's smoking. So let's have a chat about that. So I guess the main point here is, what type of pneumothorax is this guy having? Can anyone tell me just really quickly in the chat? Exactly, spontaneous. So he's having a primary spontaneous pneumothorax, and that's what we're going to talk about on the next slide. Secondary spontaneous pneumothorax is due to underlying lung disease. So things like cystic fibrosis and asthma are going to increase the risk of a secondary spontaneous pneumothorax, whereas primary means that they have no underlying lung disease. So things like smoking increase the risk of a primary spontaneous pneumothorax. But let's have a look at that in a little bit more detail on the next slide. So pathophysiology of a pneumothorax. Really straightforwardly, it's accumulation of air within the pleural space, so the space between your visceral and parietal pleura. Spontaneous occurs without trauma, such as in this case, and a primary pneumothorax is when you don't have any underlying lung disease. So typically it's young, tall, thin patients, fit and well, who suddenly get chest pain and shortness of breath. So that's what this guy has. A secondary pneumothorax, on the other hand, is normally in slightly older people and as a complication of underlying lung disease. So like we were saying, things like cystic fibrosis, asthma, COPD. So that's, make sure you kind of have that in your head, how you differentiate primary from secondary. We then have traumatic pneumothorax, so often following kind of penetrating or blunt injury to the chest. But then also don't forget about those iatrogenic causes as well. Things like line insertions and things can also cause trauma and result in a pneumothorax. And finally, as you guys know, alarm bells ringing when you think it's a tension pneumothorax. So that's when particularly your intrapleural pressure exceeds your atmospheric pressure and you get that mediastinal shift. So if all of that still sounds a little bit wordy and a little bit confused, we're going to go into a little bit more detail in the next few slides as well. So there are some lungs, and that's the pleural space that you can see there, just so you guys can visualize it. You either get a burst of a bleb or bullae or something like that, and that causes air to accumulate in that space, and that can shift your whole mediastinum in the contralateral direction. And there you go. So you've got the pleural space filling up with air, and you've got the lung collapsing on the ipsilateral side, and that can result in that mediastinal shift. Everyone following me so far? Relatively straightforward? Yeah? Good. So that's your bread and butter of pneumothorax. So this is the case that we were kind of just looking at. So primary spontaneous pneumothorax, so young, fit people, is due to a spontaneous rupture of a subpleural bleb. So what these blebs are, they're kind of small subpleural, thin-walled, air-containing spaces, if you like. And when they rupture, they allow air to fill that pleural space, resulting in a spontaneous pneumothorax. So really straightforward. For examination purposes, particularly, it's going to be young, tall, healthy males. That's kind of the most common demographic, and Asian as well. So and they often just present like they have presented in this case. They have no underlying lung disease because it's primary, and as we said, youngish patients. Smoking increases your risk. Marfan syndrome, which is your autosomal dominant tissue disorder, and then things like a family history, diving and flying. So diving and flying, people often ask, why does this increase the risk of pneumothorax? It's essentially the changes in pressure. So when you go diving, the biggest risk is that when you're coming back up to the surface, that is what normally causes your bleb rupture. So every 10 meters you actually go down in seawater, your ambient pressure increases by about 100 kilopascal. So you go down, the ambient pressure is increasing, you then come back up, and then that is what causes the blebs to rupture. And that's what the picture here is of Marfan syndrome, which is, as we said, that autosomal dominant condition, which increases your risk of a primary spontaneous pneumothorax. Moving on to secondary spontaneous. So that's what this chap has here. Well, he has COPD, which is kind of a very common cause of a secondary spontaneous pneumothorax. So it's rupture of often bullae or even blebs as well. normally presents with kind of a middle-aged or elderly-ish patient with COPD, presenting in a similar fashion to the chap that the case was on. Risk factors, like we said, is really anything which is going to cause underlying lung disease. So your asthma, COPDs, TBs, lung cancers, all of those types of things. So by definition, in your exams or in, when you get to your foundation years, if you ever see a patient with underlying lung disease that you think has a pneumothorax, always think, is it secondary? Yes, because they have underlying lung disease. And that's really important because that is what's going to affect your management, which is what we're going to talk about later. And then finally, your tension pneumothorax. So the one that we're really, really worried about. So a tension pneumothorax is essentially due to this one-way valve, which some of you may have heard of. And how we define a tension pneumothorax clinically is normally just a pneumothorax which causes significant hemodynamic instability. So why this occurs is because injured tissue forms this one-way valve which allows airflow into the pleural space during inhalation and then actually doesn't allow that air to leave. So things like trauma, mechanical ventilation can cause the formation of that one-way valve. The air continues to build up within that pleural space and it can't go anywhere. So then it just pushes your entire mediastinum in the opposite direction. So that's what this nice little cartoon kind of shows here. The air pushing on the lung, well, the lungs don't really push on the heart, but the whole thing is shifted. So then you have decreased venous return. And that is why this is so worrying. I'm going to show you some chest x-rays soon, but the main concern here is that when the whole mediastinum shifts, your venous return back to the heart is going to drop and you essentially can lose cardiac output. And that's the thing we really want to avoid. So something to really look out for following trauma, mechanical ventilation, and things like biopsies as well. And that's why we get these tension pneumothorax. Does that make sense to everyone so far? Okay, great, fantastic. So some clinical features, like we were saying before, kind of really basic, straightforward stuff. So pleuritic chest pain, sudden onset shortness of breath. Normally presents exactly like this guy did in our case, tachycardic, tachypnic, you can be cyanosed, you get hyperresonance and reduced breath sounds on the side of the pneumothorax. And then if in the case of tension pneumothorax, you can also get a hyper-expanded chest on the same side of the pneumothorax as well. And then finally, in tension pneumothorax, which is the thing we're really worried about, is that you get contralateral tracheal deviation, contralateral mediastinal shift, and hemodynamic instability. So that can cause rapid patient demise, essentially. Brilliant. So some differentials. So we at biomedicine and really clinicians everywhere, we kind of propose this rule of three when it comes to giving differentials. So when you're in your exams, in your OSCEs, wherever you are really, if you can have a list of 3 good differentials, then you're sorted. So our top differential here is a pneumothorax, as we've talked about, but you have to think, what other things can cause shortness of breath and pleuritic chest pain? Well, here are 2 really common causes, so pulmonary embolism and pneumonia. How are you going to differentiate these 3 conditions? Well, PE, you can have hemoptysis, and you can have pain or swelling in one leg due to a deep vein thrombosis, DVT. Whereas pneumonia will often have a productive cough and fever. So in terms of symptoms, that's how you can differentiate the 3. In terms of the background of the patient, PE, which we're going to talk about in the next case, you're often going to have specific risk factors, whereas in pneumonia, often kind of middle-aged elderly patients with some degree of underlying lung pathology in some cases. And then finally, PEs, ECG will show non-specific changes. You're going to go on to do a CTPA, etc. And whereas pneumonia, often you can just diagnose it on a chest X-ray if it's a typical pneumonia. So if you haven't kind of seen our webinar on pneumonia, then have a look back. I think it was the last one or the one prior to that for a really good lowdown on pneumonia. And so that's a good way to kind of differentiate the 3 in terms of particularly symptoms and their presentation in terms of risk factors. So investigations for a pneumothorax. Well, as I'm sure you guys know, the most important kind of first-line investigation you're going to be doing is a chest X-ray. And we will have a look at a few chest X-rays in a moment. So chest X-ray is going to show that visible visceral pleural edge with no lung markings peripherally to this. You know, it's got loads of air, so there's going to be no markings there. However, when you're on exam specifically, if they ever ask the gold standard or kind of the most reliable test, it's a CT chest. The chest X-ray is what's done in clinical practice. Very rarely are you going to do a CT chest for a suspected pneumothorax. But if you want the gold standard investigation, that's a CT chest. Bedside test, ECG, rule out cardiac cause. Only bloods you really need for a suspected pneumothorax is an arterial blood gas. The only other thing I might add on to that is going to be a coagulation profile. Mainly because if you're going to be shoving chest drains and aspirating things, it's probably worth knowing if this patient has an underlying coagulopathy, which can cause them to bleed a lot. And then finally, just some additional points. Obviously, there are other investigations that you can do. If you, for example, if the lung cancer is secondary to trauma, you're going to do a full trauma series. The pneumothorax is just going to be part of that in that set of investigations. If it's lung cancer, they'll need further imaging, for example. Another really important thing to mention is that all patients following intervention, which we will talk about soon, will need a repeat chest X-ray to make sure that lung has reinflated and that the pneumothorax is at least improving or resolved. And the final thing here is that in a tension pneumothorax, which is, you know, that really worrying type of pneumothorax, then you can decompress prior to imaging if there's high clinical suspicion. So if a patient presents with shortness of breath, pleuritic chest pain, you examine them, it's consistent with a tension pneumothorax, maybe the trachea is deviated, they're hemodynamically unstable, then manage it before putting them in a chest X-ray, because they might be dead by the time you see them again. So that's another really important point. Do those investigations, everyone following so far? Yeah, okay, brilliant, good, good. So here we go. So here's a little bit blurry, sorry about that. It's the chest X-ray of a right-sided spontaneous pneumothorax. So as you can see, the blue arrow here, you can see a little bit of, you know, the loss of lung markings peripherally to that blue arrow. It shows the edge of the collapsed lung. Now, a really important thing to mention here is what this white arrow represents. So this represents the correct method of measuring the size of a pneumothorax. So as you go into your foundation years after medical school and you see a patient with a suspected pneumothorax in the emergency department, you need to be able to measure how large the pneumothorax is so that you can determine what management they need. And that's how you do it. You do it like this. So you measure the interpleural distance at the level of the hilum. So here's the hilum, and you're measuring the distance essentially of where you don't see any lung markings and where the collapsed lung is. So that's what that is. You measure that in centimeters and you make a note of that, because that is what's really going to help determine your next management steps. Here's another pneumothorax. So we have, so what kind of pneumothoraxes is this? Nice straightforward question. Tension, exactly, yeah, brilliant. So left-sided tension pneumothorax, really big there. You can see loss of lung markings all the way over here. The entire mediastinum is shifted to the right. And we need to, if this patient hasn't been treated, which he clearly hasn't, this needs to be managed immediately. And then here's another tension pneumothorax, which is actually really, really good to see, actually. So you can see here, the loss of lung markings essentially on almost the entire side of the left hemithorax. The pressure effect is building up, you're shifting your mediastinum to the right. So if you see any of these two, the previous two X-rays we've just shown, you know, these patients shouldn't even be having a chest X-ray. You should have managed it by this point, particularly in such a large tension pneumothorax. Okay, let's have a look at the next question. Okay, so remember our patient, he came in, you think it's, you know, he's young, fit, healthy, he's short of breath, and he's got chest pain. This guy, he's puffing away. It shows a 0.5 centimeter pneumothorax. What are you going to do with this patient? How are you going to manage them? So remember what type of pneumothorax it is, remember how he's presented, and remember how large the pneumothorax is on the chest X-ray. Put those three things together and you should be able to answer this question. Although it is a tricky one. Give you a couple of seconds. Oh, okay. It's harder than I thought. I guess that's good to see. A lot of you guys were just getting, 90% of you were getting quite our questions right. So I guess it's good we put some harder questions in. Okay, let's have a look. Okay, 17% got it correct. Let's have a chat about, we're going to go through this properly on the next slide anyway, but essentially we need to aspirate this pneumothorax. We use a gray or a green cannula, so 16 or 18 gauge cannula. And because he's breathless, remember he's breathless, the size of the pneumothorax is essentially irrelevant. So as per British thoracic guidelines, patient has a primary spontaneous pneumothorax and they're breathless, you're going to need to aspirate it. So let's have a look. Okay, so we're going to break this down into management of a primary pneumothorax and a secondary pneumothorax. These are obviously spontaneous pneumothoraces. So these are directly adapted from the British thoracic guidelines. This chest X-ray here is just to remind you how to measure the pneumothorax. So let's start at the top. So you think, like in our chap, we think he's had a spontaneous pneumothorax. He's not hemodynamically unstable, and it's not bilateral. So we don't need to think about chest drains or anything like that. We then go on to the next step. We have to ask ourselves, firstly, is this chap over 50 and does he have a significant smoking history? The answer is no. Well, then we're thinking probably primary. And then you need to ask yourself, is there evidence of lung disease on examination or chest X-ray? If your answer to these two questions is no, it's a primary spontaneous pneumothorax, and we go down this pathway. So when I asked you the question on the last slide, we are at this point, right? So we then need to have a look at the chest X-ray, and we have to have a look at their symptoms. So what size is the pneumothorax on the chest X-ray? Well, if it's over 2 centimeters, you're going to need to aspirate. And or if they're breathless. So if it's less than 2 centimeters and they're breathless, you're going to need to aspirate. If it's more than 2 centimeters, regardless of their breathlessness, you're going to need to aspirate. The only time when you're not going to aspirate is if it's less than 2 centimeters and they're not breathless. Then, like the 60-odd% of you said, then you could discharge this patient. But that is the only circumstance in a primary spontaneous pneumothorax. Otherwise, we're going to aspirate. So essentially, aspiration is you're taking out a certain amount of air. So the British Thoracic Society says less than 2.5 liters. And the pneumothoraces I've aspirated, it's often significantly less than that. And you're literally putting in that cannula and taking out that air. It's as simple as that. But you're not leaving a drain and you're not leaving anything in there. You're just taking the air out and reassessing. So you take out that air and then you reassess. So you do another chest X-ray and you assess their breathing. Is it successful? If so, then you can consider discharging them. If they're still short of breath and the size hasn't actually reduced to less than 1 centimeter, then we pop a chest drain in. So essentially all you need to think about is, the most conservative management is sending them home. The next step up of that is going to be aspirating because you're not leaving a tube in there, you're just taking out air. And the thing that's even kind of more drastic than that is going to be putting in a chest drain. So if aspiration fails, then you pop a chest drain in, and that's 18 to 14 French. So a small bore chest drain. Don't go shoving in a massive chest drain because actually the evidence shows the outcomes are similar, but a large chest drain causes a lot more pain and often more complications. Does that make sense to everyone? So that's literally everything you need to know about managing a primary spontaneous pneumothorax. Brilliant, okay. Secondary. So back to the top, we're asking ourselves the same questions. They're coming with a pneumothorax. Are they over 50 years old with a kind of, spontaneous, significant smoking history? If so, it's secondary. Or have they got evidence of lung disease on examination or on chest x-ray? If so, it's a secondary pneumothorax. Then the next question is exactly the same as last time. Is the size above 2 centimeters or breathless? If it is, you go straight to a chest drain. So this is really the most important, well, one of the most important differences here is that the take-home message from a secondary pneumothorax is you are always going to admit the patient with a secondary pneumothorax. You will never send this patient home immediately. So either they're going to need a chest drain straight away, if they're breathless or it's a large pneumothorax, pop a chest drain in. If not, the next question to say is, exactly how big is the pneumothorax on the chest x-ray? If it's between 1 to 2 centimeters, we're going to aspirate, just like we aspirated with the primary pneumothorax. We're then going to reassess. If it's not successful, pop a chest drain in. If it is successful, you're still going to admit them. You're still going to admit them. Often they'll need high flow oxygen, and you're going to observe them. So, and then obviously if you go back here, if it's not between 1 to 2 centimeters, then you're also going to admit them. So essentially, like I said, the golden rule with a secondary pneumothorax is all patients are going to need to be admitted, but you just need to think, are you going to aspirate? Are you going to put a chest drain in? Or are you just going to monitor them? So all I'd recommend is, obviously all these slides are available online. Sit down, learn the algorithms. It's actually super straightforward, and you'll know how to manage a pneumothorax. Everyone make sense of that? Okay? Okay, brilliant, good. And the reason we give oxygen is because that actually helps kind of reinflate that lung. So often when I've done pneumothoraces, even if the patient's saturating well in a primary pneumothorax, you're often going to give oxygen to help that lung reinflate. And yeah, here's a summary of everything we just covered. It looks a little bit more daunting when you put it all on one page, but now we've split it up. Hopefully you guys understand it. So essentially a little bit more in depth about how we're going to manage a spontaneous one. Well, needle aspiration, second intercostal space, midclavicular line, chest drain, fifth intercostal space, mid-axillary line. This is kind of your bread and butter ones, more often taught really early on. But yeah, try and remember that. And then triangle of safety, super important. We're going to have a look at the anatomy of that soon. In terms of, I just thought I mentioned second intercostal space, midclavicular line. There are differences in schools of thought with that. Guidelines haven't quite caught up with exactly where these should be done. However, in clinical practice, it's still often here, but often they can be done at the same place as the chest drain as well. But this is kind of what most people still follow. But as I said, it differs in clinical practice between clinicians. In terms of where you're going to pop your needles and chest drains in, well, always remember it's above the upper border of the rib to avoid the neurovascular bundle, which I'll show you on the next slide, and high flow oxygen, as I mentioned, if appropriate. So if the patients are, got long-standing COPD and they're retaining CO2, then obviously we're not going to pop them on high flow oxygen. And here's your neurovascular bundle. So a side view of it. Here's your rib. Here's your rib. Here's your neurovascular bundle. And this is what we're trying to avoid. So you want to pop it above the rib. So up here or up here is what's going to help you avoid, puncturing an artery or damaging a nerve or something like that. Okay, so moving on to management of a tension pneumothorax. So pretty straightforward actually. High flow oxygen, urgent needle decompression. So this is a 14 gauge cannula at the second to third intercostal space midclavicular line. So around here-ish. And then these patients will need a chest drain immediately after. So remember, this is an emergency. Now the next slide is a little treat that we put together for you guys. Here's a picture I took of myself earlier this morning. As you can see, lying on my bed, looking at, this is how we're going to insert our chest drain. It's the best we could do. All the images online were copyrighted, so we had to make our own. Shout out to our design team, they did a great job. So if you can't remember it from this, you're never going to remember it. So let's have a look. So this is where you're going to insert your chest drain. I can't even take it seriously. This is where you're going to insert your chest drain. So the triangle of safety is what we call it. It's kind of more shaped like a trapezium. So it's formed anteriorly by the lateral border of pectoralis major. It's formed laterally by the lateral border of latissimus dorsi, inferiorly by the fifth intercostal space, and superiorly by the base of the axilla. So that's literally it. So that delightful picture of myself. Make sure you understand exactly what these boundaries are. Really, really classical question in your exams. So unfortunately, like this is how I looked before I went into hospital, but now I've put on a little bit of weight, and now I've put this drain in me for some reason. But yeah, that's what it looks like in that trapezium or triangle of safety. And that's where you're going to put your drain in. Does that make sense to everyone? Insta versus reality, exactly. Okay, question time. Okay, so this patient that we were talking about before we got distracted by myself topless, the patient presents with a second pneumothorax and is referred to thoracics or thoracic surgery. Which surgical intervention has the lowest recurrence rate? Tricky question. Which surgical intervention has the lowest recurrence rate? So surgical chemical pleurodesis, laparoscopic pneumonectomy, laparoscopic lobectomy, VATS pleurectomy, or an open thoracotomy and pleurectomy. This is more of a thoracics question, but it can definitely come up in your exams. And it's useful to know. I had a thoracics job, and when I started, I didn't really know what any of these words even meant, to be honest. Okay, let's have a look. Yeah. Okay, so everyone thinks everything, which is as expected. So let's have a look. There we go. 18% of you, brilliant. Open thoracotomy and pleurectomy. So let's have a look at our surgical options for pneumothorax then. Okay, so surgery is normally really going to ever be indicated in patients who have recurrent pneumothoraces. So a few indications for referral to a thoracic surgeon are noted down here, which we'll have a look at in a second. But in terms of our surgical options, so let's work through these briefly. So open thoracotomy and pleurectomy, open surgical procedure, you're removing the pleura or part of the pleura. It's associated with the lowest recurrence rate, so only around 1%, but has a higher morbidity, i.e., longer stay in hospital, high rates of infection, high rates of bleeding, that kind of thing. Contrast that to a VATS pleurectomy. So this is video-assisted thoracoscopic surgery pleurectomy. So minimally invasive chest surgery, basically. It has a lower morbidity. So all those complications I mentioned are lower, but the recurrence rate is higher. So around kind of 5-ish%, I think the literature still says. And then finally, surgical chemical pleurodesis, less popular now. You essentially, it's an operation and you use things, I think talc is what's most commonly still recommended, but it's surgery and you put talc in rather than removing the pleura itself. It's less popular now and has higher rates of recurrence than the other two options. So these are surgical management options. There's also, if you guys have heard of medical pleurodesis, that's essentially where you put something like talc down a chest drain. That's actually very rarely done now, and that's mainly for patients who aren't appropriate for surgery. And all the talc or the chemicals do are cause adherence of the two pleura together to prevent air from filling that space again. So most commonly what's done now is a VATS pleurectomy, to be honest. And then finally, indications for referral to a thoracic surgeon. Here are a few of them. First, contralateral pneumothorax, bilateral spontaneous pneumothoraces, second ipsilateral, etc. But just have a read of those. They all make kind of logical sense, to be honest. So for example, if you put a chest drain in and it's been in for kind of 5 to 7 days and the pneumothorax hasn't resolved, then you can consider going to surgery as well. And then your professions are things like pilots and divers are specific ones. Yeah, have a memorize of those 6 key indications. These are straight from the British Thoracic Society as well. Okay, so here's something we introduced kind of, I think it was in our last webinar, kind of a top decile question or distinction level question, whatever you want to call it, for those of you who are amazing at life. So, on discharge, what advice would you give a patient after aspiration of a pneumothorax? So a patient has had a pneumothorax aspirated, no chest drain, nothing like that, no surgery, they've just had it aspirated. What advice are you going to give them when you're discharging them? Have a think. Okay. Okay. Not as hard as we thought. Okay. Good. So maybe actually the harder question was the one before this. So let's take that as the top decile question. But yeah, absolutely right. So none of these are correct. And I'm going to explain why on the next. Well, actually, I can touch on it here. So the main thing that people often get confused about is when you can fly. So the main rule to remember here is that you can fly 1 week after a post-check chest X-ray. So you had the chest, you had it aspirated or drained. You have a chest X-ray, and if that chest X-ray shows that the pneumothorax has resolved and the patient's symptoms have resolved as well, then you can fly 1 week after that. So it's not that you can fly after 1 week. But yeah, I'll show you the two main things to mention. So whenever you're discharging patients after pneumothorax has been treated, these are the main two questions that they ask. Well, flying, definitely, diving less commonly. So flying, patients can fly 1 week post-chest X-ray, as we said, as long as the pneumothorax has resolved. Diving, so I think the last question was, you're never going to be able to dive. Technically, not quite correct. The advice is that you avoid it indefinitely, but in people who, are divers for a profession, for example, often they're going to need to go diving. So they can still dive if after they have had a definitive bilateral surgical pleurectomy. The pleura has been removed from both sides, post-operative CT chest, and normal lung function. So essentially, there's a lot of hoops to jump through before you can dive again, but you can dive again, potentially. Good. Hopefully all of that makes sense. And just a recap, really, of everything we just talked about. So now we know the difference between our types of pneumothoraces. We know how they present. Chest X-ray is the most important form of imaging. Tension pneumothorax is an emergency. Second intercostal space, mid-clavicular line, aspirated ASAP. There are a few options for management, and now we know when to do each of those. A few surgical options, and make sure you give proper advice to patients after they have had a pneumothorax aspirated or drained. I know there's a lot of questions in the comments here. What we normally do, if you haven't seen this before, is we make a question and answer kind of PDF, and we'll put it on our website. One of our doctors will answer all of your really common questions that have come up in the chat. Okay, hopefully that was useful. That's really almost everything you really need to know about pneumothorax. So let's move on to pulmonary embolism. So, history. 65-year-old female presents with sudden onset shortness of breath and pleuritic chest pain, remarkably similar to our last chat. She has a history of a right-sided mastectomy for breast cancer 1 year ago. There's a BMI of 27. Observations are there. So really absorb, it's a really short history, but absorb all of that because this is really important for the questions that are coming up. So 65 years old, sudden onset chest pain and shortness of breath, right-sided mastectomy a year ago for breast cancer, BMI of 27. What do you think about these observations? Are we worried? Are we not worried? Yeah, yes, exactly. Very, very worried. Yeah, I'd be crying, basically. Tachycardic, hypotensive, tachypnic, hypoxic. Yes, concerning. Let's have a look at the question. Okay. So, as per NICE guidelines, which of the following risk factors does this patient have for developing a pulmonary embolism? I think the code might be different, 43248. I think that is different. So you might need to put in the new code. Female, previous breast cancer, 65 years old, BMI 27, previous surgery. Okay, let's have a look. Wow, this was a hard one as well. Okay, so actually, give you guys 10 seconds because why not? There you go, 6%. Wow, okay. So NICE guidelines. So the NICE guidelines on wells are very, very, very similar in terms of risk factors for pulmonary embolism. And we'll talk about how they differ in very small ways. Being female is not a risk factor for pulmonary embolism. Previous breast cancer, as per NICE, is not a risk, or previous cancer, full stop, is not a risk factor for pulmonary embolism. NICE guidelines say active cancer is a risk factor. BMI of 27 is not a risk factor. Obesity is a risk factor, so BMI above 30. Previous surgery is not a risk factor. But recent surgery within 2 months is a risk factor, as per NICE guidelines. That leaves us with 65 years old. So age over 60 years old is a risk factor, as per NICE guidelines. So that's why that answer is correct. And we will talk about a bunch of other risk factors for PE, as well as what else NICE say and the Wells score says. So what is a pulmonary embolism? Quite straightforward. Obstruction of your pulmonary vasculature due to an embolus. Often patients may, well, a proportion of patients will have a deep vein thrombus in their calf, for example, which has then dislodged and lodged up in their pulmonary circulation. Virchow's triad is really useful to remember your risk factors for thrombosis, which we'll look at on the next slide. Like we said, often due to a DVT, the embolus dislodges, goes to your lung, your pulmonary circulation, and obstructs our vasculature. It causes an increase in your pulmonary vascular resistance. So then you need to think, you know, anatomically what's happening next? Well, your right ventricle is going to be pumping against a higher pressure because there's a clot blocking the vasculature. So what this can ultimately result in is things like arrhythmias, pulmonary infarction, where a segment of the lung essentially dies because of loss of blood supply. Cor pulmonale is really important. So like I said, remember your right heart, your right ventricle is going to be pumping against higher vascular resistance because of that embolus. The right heart can then dilate. You essentially get right heart failure. So that's a really, really important complication of larger PEs, so massive PEs, for example. And then cardiac arrest is also possible, hypoxic arrest, or due to reduction in your filling of your ventricles as well because of heart failure. So yeah, it's that's also something to be aware of. So pulmonary emboli, particularly as they get really big, so massive PEs can cause big problems. So here is your Virchow's triad. So Virchow's triad covers hypercoagulability, endothelial damage, venous stasis. And like I said, this helps you remember your risk factors for PE and DVT, any type of thrombus. So the ones in bold are the major risk factors as per NICE guidelines. And the other ones are kind of minor risk factors. So hypercoagulability, things like pregnancy, things like cancer are major risk factors. But then we also need to think about you know, the pill, HRT, so combined oral contraceptive pill, hormone replacement therapy, thrombophilias, those types of things. Things that can cause endothelial damage, so trauma, fractures, previous thromboemboli as well. These are major risk factors. And then venous stasis. So NICE, like I said, says recent surgery within 2 months. The Wells score says 1 month. So that's an important thing to differentiate. So Wells score is your scoring criteria to determine the likelihood of a pulmonary embolism. So NICE say recent surgery within 2 months. Wells score says recent surgery within 1 month. deep vein thrombosis, obviously the presence of a deep vein thrombosis is a major risk factor. And then significant immobility as well, along with your other minor risk factors in addition. So the two main differences between NICE and WELL score, there are probably a few more, but these are the two main ones, is that active cancer, according to NICE, is a major risk factor, whereas according to WELL score, is a little bit more specific than that. So we'll talk about that in the next couple of slides. And the other thing that differentiates NICE from the WELL score is going to be NICE say recent surgery within 2 months, whereas WELL score says recent surgery within 1 month. So have a remember of, just try and remember those two things. Everyone following me? Does that all make sense to everyone? Yeah? Fantastic. So clinical features, essentially like this lady has presented with. So chest pain, shortness of breath, cough or hemoptysis. You can have a bit of a low-grade fever. It does happen in a reasonable proportion of patients, actually. And then syncope. So if you're suspecting a PE in a patient that's had a syncopal episode, that's very, very worrying. It can show hemodynamic instability, loss, essentially it's due to hypoxia to the brain, right? So that's a big, big problem. And then signs that you'd expect: tachypnea, tachycardia, hypoxia. You may have evidence of deep vein thrombosis as well in a proportion of patients. Hypotension, so the way that we can differentiate non-massive PEs and massive PEs, a good way to differentiate is basically anyone who's hemodynamically unstable can be assumed to have a massive PE. So systolic blood pressure under 90 is a good indicator, but also remember that in younger patients, the blood pressure often doesn't drop early on, it drops much later. Particularly in young patients. So that's how you're going to define whether it's a massive PE, and that's also going to influence your management as well. If you have raised JVP, it indicates cor pulmonale, so increased load within that right heart causes a raised JVP, and then right ventricular strain as well, which suggests evidence of cor pulmonale as well. It's going to be evidenced by a right parasternal heave. So those are your clinical features. This is exactly the same as the differentials list from our pneumothorax slide, which makes everyone's life a lot easier, mainly because they're all causes of pleuritic chest pain. They all cause shortness of breath. But exactly like we said before, we can differentiate it based on symptoms, based on risk factors, and on some investigations as well. Okay, so now this is exactly the same case, but I wanted just to remind you once more of exactly what's happening with this patient to help you with the next question. So remember, 65 years old, right-sided mastectomy 1 year ago for breast cancer, BMI of 27, hemodynamically unstable. Okay. What is this patient's WELL score? So hopefully you remembered what was on the last slide. I've kind of forgotten. So BMI 27, age 65, previous breast cancer. We think, obviously our top differential here is the pulmonary embolism as well. Bear that in mind and see what you think. Give you a few moments. Okay, let's have a look. 4, maybe. 4.5. I'll show you why on the next slide. Well done, 22%. It's a tricky question, but also one that could certainly come up. So 4.5, well, 4.5 is because of, where is it? PE is our #1 diagnosis, or equally likely. So that's 3, and she's tachycardic. 3 plus 1.5, 4.5. So the take-home messages from the WELL score are this. Remember the 2 factors that cause the high, well, not cause, that are associated with the highest number of points on the WELL score. The clinical signs and symptoms of DVT scores you the most points, and PE is the number one diagnosis or equally likely, scores you the most points. That's probably the most simple question they could ask about the Wells score. So remember that. And then also remember exactly what the criteria are. So which is essentially what's shown on this table. So memorize the table. I don't think necessarily learning every single number, is it 0.5, is it not, is necessary. But if you can, then that's great as well. But yeah, the take-home message, like I said, remember what each of the clinical features are, and remember the two factors that score the highest number of points. And then, like we said already, remember those two differences between NICE and the Wells score in terms of surgery and active malignancy. So like we said, NICE say active malignancy, Wells say malignancy with treatment within the last 6 months or palliative. That's one difference between NICE and the Wells score. Everyone on board following thus far? Good. It's good to see. So investigations. So we like to follow a bedside bloods imaging special tests approach, mainly because it means you won't forget anything and it's a really, really structured way to do things. So bedside ECG, so sinus tachycardia is the most common finding, but you can also have features like right bundle branch block, right axis deviation, S1Q3T3. So what we'll do is we'll do an ECG webinar on, well, a webinar on ECGs, and we'll talk through all of these types of things. But yeah, the most important thing is, sinus tachycardia is the most common, but the thing that often comes up in exams and your consultant might ask you is about S1Q3T3, which is more specific to pulmonary embolism, but it is actually very rare in clinical practice. Bloods you'd consider, ABG may demonstrate respiratory failure. Imaging, chest x-ray is usually normal, but is often going to be your first line investigation. If you're requesting a CTPA, which is a CT pulmonary angiogram, often radiologists will ask for a chest x-ray first anyway, so usually that's going to be your first investigation, but it's not really going to be diagnostic. An other form of imaging is going to be an echo. So an echo we do to assess that right ventricular strain in a massive PE. So you have a massive PE, like we said, can cause cor pulmonale. So we need to assess the strain that's being put on that right ventricle. And then the specialist tests, which you're going to do, are going to be dependent on the Wells score, which we just calculated on the previous slide. So CTPA is performed in patients with a high probability of PE. That's a score of more than 4. This is super important. CTPA for high probability, Wells score more than 4. Or a D-dimer is performed if it's a low probability. That's a Wells score 4 or less. So 4 or less is low probability, you do a D-dimer. More than 4, you do a CTPA, and it's high probability. Now, there's going to be, obviously, this is a simplified version. In things like pregnancy and things like renal failure, you're going to think, outside the box a little bit. Some of you guys may have heard of a VQ scan. Each trust has different guidelines in terms of VQ scans versus CT pulmonary angiograms. The Royal College of Obstetricians and Gynecologists really says that either a CTPA or VQ scan can be carried out, and the decision is based on local guidelines. So in reality, a CTPA carries an increased risk of maternal breast cancer, and actually a VQ scan carries an increased risk of cancer to the fetus or the child. So that's why it's such a balancing act, because there's risk to the parent and there's risk to the child as well. So it's a very, very difficult decision. There's no black and white answers, and it's going to need a discussion with, specialists essentially. So that's just one other point I thought I would add. Sinus tachy, straightforward, most common ECG finding, like we mentioned before. And this is right bundle branch block. So broad QRS, you've got that, bunny-shaped ear pattern in your precordial leads, V1 to V3. So yeah, this is possible as well. And then here's a nice diagram that we made earlier. We're a big fan of diagrams like this, as long as they're simple, nice flow charts. So probability of PE, low probability, D-dimer. If it's positive, you then end up doing a CTPA. And then, is there a PE or not? That's going to depend. That's going to determine your treatment. If your D-dimer is negative, you don't need treatment. So your D-dimer is negative. There are obviously a whole host of things that can increase your D-dimer. infection, malignancy, cancer, really just anything. So a positive D dimer is irrelevant if you're trying to actually diagnose a PE, but it does help you determine whether you're going to go on to a CTPA. But whereas a negative D dimer often, well, in a vast majority of cases, means there's not going to be a DVT or a PE. So that's how you remember it. And then finally, high Well score, so high probability of a PE. I'm going to do a CTPA, treatment or no treatment. But yeah, that's the basic flowchart of investigations for pulmonary embolism. Obviously, that's a little bit simplified. There are other scoring systems you can use, such as PERC score, which is used in clinical practice, but often isn't asked about in exams. Yeah, if you remember this, you'll be fine. Okay. Oh, wow. A lot of you are answering already. What additional investigation should you consider in this patient? So this lady who has presented, 65 years old, we can't really think of any immediate risk factors other than her age. Nothing has seemed to have provoked this pulmonary embolism. What other investigations are you going to think about? CT head, abdominal ultrasound, CT abdo-pelvis, abdominal X-ray, or factor 5 Leiden. Easy, easy peasy. All right, good. Yeah, that's right. CT abdo-pelvis, which we'll talk about on this slide. So for patients with an unprovoked pulmonary embolism, so this means that there are no, obviously, like the name suggests, no provoking factors. So NICE say that a provoked PE is one with a proven risk factor within the last 3 months. 3 months, that's what NICE guidelines say. So if they have a specific risk factor that has provoked their PE within the last 3 months, then we're going to have a look at these options. So all patients, and these investigations at the top here, including the CT abdo-pelvis, are because you need to investigate for an underlying malignancy. And that's because malignancy increases the likelihood of thrombosis. So all patients need a full set of bloods, chest X-ray, and urinalysis. Patients over 40 years old will need a CT abdo-pelvis. Well, they don't need it, it should be considered. Because obviously they're in a higher risk group for malignancy. And then we need to consider some investigations for thrombophilia, which was what our factor 5 Leiden was. So antiphospholipid antibodies, so if you have an unprovoked PE, can be considered. And whereas hereditary thrombophilias should only really be considered if you have an unprovoked PE and a first-degree relative who has had a DVT. So that's why we're not going to do factor 5 Leiden in the previous question, is because there's no mention of a first-degree relative with a DVT. So management, we're nearing the end now. Actually, we've got I think a couple more questions. So management, massive PE. So like we were talking about, patients who are hemodynamically unstable, their blood pressure is low, they look really, really ill, they're really tachycardic, then you're going to thrombolize these patients, as long as there are no significant contraindications to thrombolysis. Then we use something like alteplase. Non-massive PEs, which are the majority of PEs, thankfully, this is what you need to remember. So orally anticoagulate these patients, either with warfarin or a direct oral anticoagulant, something like rivaroxaban, for 3 months if it's provoked, like we talked about before. So a risk factor within the last couple of months, 3 months, I think it was, or 6 months if unprovoked. So that's really the main points that you guys need to remember. So you continue the anticoagulation for a further 3 months if the pulmonary embolism is unprovoked. And then finally, another really important thing to remember is that low molecular weight heparin is used for 6 months in active cancer. So patients with active cancer who have had a PE because of that will use low molecular weight heparin rather than an oral anticoagulant. Trust guidelines often differ mainly in terms of this first bullet point. So the trust I was at when I first joined in F1 they advise that all patients with a newly diagnosed PE should be started on low molecular weight heparin immediately. Whereas they then changed this when I was in F2, when I was working in the emergency department, they then said, actually, patients don't need to be started on low molecular weight heparin immediately. They can just be started on a DOAC, so like rivaroxaban. So that often differs between trusts, but if you learn this, you'll be absolutely fine. Alternative treatments, so these are kind of special interventions that are used in a subset of patients. So things like an IVC filter, so an inferior vena cava filter, patients with recurrent PEs despite anticoagulation. So essentially a device that you put in the IVC to stop those clots going into the heart and then going into the lungs. And then surgical embolectomy is exactly what it sounds like. So surgically remove the embolus. Another option would be percutaneous catheter-directed thrombolysis as well. Either of those would be reasonable, and that's when thrombolysis has failed or is contraindicated. There are a bunch of absolute contraindications for thrombolysis. There are a bunch of relative contraindications. I'd recommend learning those. We haven't included them here just because it'll be information overload, but have a read. So yeah, like I said, try and remember this. If you remember this, you'll be absolutely fine for exams. In reality, things differ a little bit from place to place and depending on the clinical circumstance. So a recap. So pulmonary embolism presents with shortness of breath, pruritic chest pain. You can remember those risk factors using Virchow's triad. We need to remember about, massive PEs can be really dangerous. Cor pulmonale, patients can rapidly deteriorate. Those are our initial investigations, which we now know about as well. If you have an unprovoked pulmonary embolism, you're going to need further investigations. And, then we have to think about our management options, which you guys know about. Before you rush off, we have top decile question. Now this, I promise, this is just insanely hard. If you get this, you might as well be a doctor already. Oh no. How do I stop that? Oh. Okay, there we go. All right. A patient is started on low molecular weight heparin for a PE. Bloods checked 5 days later show that. What is the underlying cause? We think it's hard. Hopefully you think it's hard. And before you rush off after this question, all we ask is for your feedback, please, which we've got a feedback form on the next slide. And please just tell all your friends about our webinars would be great. And keep an eye out for our platform, which is coming out. But yeah, definitely, please sign up for our group. That's where we're going to be releasing all the rest of our invites, the rest of our platform with hundreds of these multi-step SBAs. That's where you can find a lot of things, our new textbook and everything like that as well. So yes, please sign up. Biomedicine for Students is what our Facebook group is called. So I'll give you guys a couple of moments for this question. Okay, let's have a look. Oh man, you guys are just too smart, basically. That's a shame. Okay, fine. I mean, do you want me to work through what each of these are as well? Or do you want me to work through this at all? Yeah, okay, let's do it. Okay, okay, so let's start with the correct answer. So what we have here is heparin-induced thrombocytopenia. So normal HB, normal white cell count, but the platelets are really low. So this normally happens around day 5 in a certain group of patients after they start heparin, such as low molecular weight heparin. So what happens is that you give a patient heparin. Heparin binds to platelet factor 4, and this forms something called the heparin platelet factor 4 complex. So heparin binds to platelet factor 4, forms the heparin platelet factor 4 complex. Antibodies, normally IgG, are then produced by your body against the heparin platelet factor 4 complex. This then causes platelet activation, which actually initially increases your risk of clots forming because all your platelets are activated, but then a fall in your platelet count because all the platelets are activated. So that's why you get thrombocytopenia. Does that make sense to everyone? I can work through the other 4 as well if you'd like. Yeah? Okay, good. So let's start from the far left. So antithrombin antibodies associated with lupus anticoagulant in patients with SLE. Simple as that. Anti-GP2B and 3A associated with idiopathic thrombocytopenic purpura, so ITP. ADAM, TS13, is associated with thrombotic thrombocytopenic purpura, TTP. We're definitely going to do teaching on hematology because I know people really find this complicated. And then C-ANCA is an autoantibody seen in granulomatosis with polyangiitis, so what was previously known as Wegener's, which is a vasculitis. Brilliant. So hopefully you guys found that really useful. So let's, if you could please fill out our feedback forms, we would love you forever. We also please ask you to join Bite Medicine for Students. That would be brilliant. We're putting the feedback form in the comments here. You can also use the QR code here. Our platform's coming out in a few days. Like I said, it's got a massive textbook that we've made specifically for you guys. It has hundreds of these multi-step SBAs. Please join us on Bite Medicine for Students. Tell all your friends. These are obviously, you know, free, so we're trying to help you guys out the best that we can. And yeah, your feedback would be amazing. We also have a Q&A after this where we'll take a few more questions. We also have like a proper Q&A tomorrow with loads more SBAs as well. So this will be a brief one today. If you guys are interested, you can stick around for it, where you can just ask me any other questions about life and medicine. And yeah, please leave your feedback. I can